So let's just jump right into it. I have been observing a lot of brain injury stuff out there, and I kept seeing on one of the Facebook groups, on multiple groups, people posting about your research, and then just it's like 20 comments, 30 comments, 50 comments, 150 comments. It's just like people responding that this is something that they are experiencing, and finally there's research out there, and you have also put out a YouTube video which is very friendly to us, and let's get deeper into it.
Again, my name is Shan Siddiqi. I'm a neuropsychiatrist, and I emphasize that because I'm often known mostly as a neuroscientist and as a teacher, but I like to say that I'm pretending to be a neuroscientist. I started out as a clinician, as a medical doctor and a mental health professional. I saw a lot of people who were struggling with traumatic brain injury, and it was very obvious to me that this is something different. And patients recognized it, and even doctors recognized that the depression after a TBI it doesn't seem to be the same thing. But we didn't have a lot of great research on it, and so we wanted to go tackle that a little bit further. Why wasn't there great research on it? The main reason was because it was hard to study, and so we as the technology got better, we started to develop the capacity to do this sort of stuff. I want to make sure to give credit where it's due. I didn't develop the technology. I just learned how to figure out how to use it to answer this specific question. And the question that we're specifically talking about is this a distinct syndrome? Um, it's This is an important one because, of course, if we want to find better treatments for something, we want to try to understand a little bit about what it is. I think in the title of this talk that was sent out, the word was just depression or a distinct syndrome. I want to clarify that the depression, those two things aren't mutually exclusive. Something can be depression and also still be a distinct syndrome. After for the paper that you guys are talking about, after it came out, of course, it got a lot of media coverage, as you've mentioned. Some people reached out to me and said, "Hey, are you implying that my depression is somehow less real?" And wanted to make it clear that just because one is more structurally based doesn't mean that the other one is any less real. Both are equally real. They just need to be different forms. Um, just as a disclosure, this is where all my grant funding and other funding comes from. Uh, so here's what I'm going to talk about today. There are a few specific things. First of all, how do neuropsychiatrists think about traumatic brain injury? And often it's a little bit different from how neurologists think about it. Uh, and then why do we think that TBI depression is different from other types of depression or from TBI without depression? And then I'll introduce you to a new approach to treatment, which is targeted brain stimulation, which is something that we're working on developing now. Um, I'll talk about characterizing brain features that are unique to TBI depression. And this is the topic that Dan actually told me or asked me to talk about. But I think it's, as you mentioned, Dan, I have a YouTube video on this topic already, but I thought that what I can talk to you guys about today is contextualizing it. I'll start by talking about the reasons why we did this work to find better treatments, and then describe sort of how we actually did it. And then finally, I'll talk a little bit about what's next, about where we can hopefully go in the future and how we can use help from other people, motivated people like you guys. So, what do I mean by neuropsychiatrists? So, TBI, I often think of as a neuropsychiatric syndrome. This is important because it affects where patients often end up, what clinic you end up in, for example. So in the case of military service members, the most common symptoms reported by service members coming back from a war with TBI are sleep changes, memory impairment, irritability, headaches, fatigue, impaired concentration, hearing problems, anxiety, frustration, and executive dysfunction or difficulty concentrating or sustaining attention. So if you look at most of these symptoms, these are the kinds of symptoms that often lead people to end up in a psychiatric clinic. Uh, and so why is it that we're sending people always to a neurologist or just to a general psychiatrist when really this is at the intersection of the two? So that's what I mean when I say neuropsychiatry. In my case, I am a psychiatrist by training. I went to medical school, I did a psychiatry residency, and then did a little bit of extra training in neurology so I could become a neuropsychiatrist and specialize in seeing patients with TBI and other neurological disorders that cause these sorts of symptom patterns. However, there's a lot of stigma associated with going to a psychiatrist for some people. They say, well, I'm not crazy. I have a brain injury. And the idea that That going to a psychiatrist means that that there's something wrong with you or that you're crazy is one of the ideas that we wanted to tackle, that we wanted to combat by bringing more science into this. There are a lot of reasons why this is important and why this is important specifically to neuropsychiatrists. By the way, this isn't just me, there's an entire American Neuropsychiatric Association. And when I went there, I presented this work. They were really excited about it. When you talk to neuropsychiatrists, they'll say, of course, TBI depression is a distinct syndrome. We've known this for a long time. But they were excited that we had some science to understand the physiology. So in this group of physicians, we know this and we believe this. Uh, but what I often try to tell to other physicians and also to other scientists is that TBI independently increases the risk of depression, potentially by eightfold. It's 8 times more likely. So it's not just an incidental comorbidity. Right? Most of those people, those patients who experience depression after TBI are never offered any medications or psychotherapy. There are a few different reasons for that. One might be because they end up in a neurology clinic rather than a psychiatry one. But another one might be because the treatments don't actually work very well for people who are suffering from TBI. What do I mean when I say neurology clinic rather than a psychiatry one? Well, I've had many patients end up in my clinic who come to say, "Hey, I've been to all these different doctors, and they all tell me that I'm not the right doctor for them, or that they're not the right doctor for me." That they say, "Oh, well, you don't have a neurological problem, you have a psychiatric problem, or you don't have a psychiatric problem, you have a neurological problem." And so I think a huge part of this has been to tell people, "Yes, I'm the right doctor for you. We know the right place to where we need to start." TBI depression also independently predicts poor outcomes beyond TBI alone or depression alone. So if you take TBI and its disability associated with that, and you take the disability associated with depression and you add them together, that doesn't explain all the disability that people get from TBI depression. It's been shown that it's synergistic. It's in a bad way. And improvement in depression also leads to all sorts of improvements in function, both cognitive and motor function. So but so that suggests that this is important. Now, that I think we can all agree that it's important, but is it different? Well, there are some ways in which TBI-associated depression is similar to run-of-the-mill major depression, as you might call it. For example, people struggle to be motivated by a reward often. Often people struggle with sleep, people struggle with concentration. These are symptoms of depression and of TBI-associated depression. Another similarity is they're traditionally treated similarly with antidepressants and with cognitive behavioral therapy. But there are also a lot of things that are different about it. And again, if you talk to somebody who sees a lot of these patients, they'll say, "Oh yeah, of course they're different." But of the people who don't see a lot of these patients, they don't often recognize that as much. Um, One is that the TBI associated depression often gets worse over time. Once you get it, it doesn't always start immediately after the TBI. It often starts months or maybe even a year or two later, and it stays there and it's progressive and chronic. That's different from major depression, which if there's an emotional stressor that triggers a depressive episode, it tends to start right then, and it comes in episodes. There are periods where it gets better, periods where it gets worse.
Can I ask you a question about that?
Yeah.
Do you have any insight as to, in the context of the brain injury, why the depression seems to not occur, so soon?
I have some opinions on this. This hasn't been proven, but my so what I'm going to tell you right now is speculative. It's
Okay,
not based on
that's
hard
all right.
science.
That's okay.
Yeah,
Your
that's
speculation's as good as anybody else's, but go ahead.
yeah. But my speculation is that and I actually have a slide later where I was going to speculate on it anyway, but I'll do it earlier. What I think is happening is that after a brain injury, your brain does a lot of things to preserve certain functions like breathing and motor function and things like that.
Hmm.
And as it heals, it prioritizes preserving those core functions that are necessary for life, and it's willing to sacrifice mood, which I think is not necessary for life. So over time, the more you heal from the other functions, the more you start to lose some of the mood regulating functions because your brain is diverting resources away from them. That's my speculation, but we haven't tested that yet.
Thing it's what I find interesting is you speak about that almost, for lack of a better way of putting it, purely from a medical perspective, as opposed to including in that context the emotional um, impact of the trauma
Yeah, so
from
so
the
I
injury.
think the emotional impact of the trauma is important, but I think it's independent. I think these are two independent things. I think there's the emotional impact of the trauma, of course, will act as a burden and will slow you down and be emotionally taxing. But in general, the emotional impact of trauma leads to an episodic depression. Emotional impact of all sorts of different kinds of trauma leads to
Yeah,
depression, right?
right,
It
right,
doesn't have
right,
to be a traumatic brain injury.
right,
It
right,
can be
right, right,
yeah, it
right.
can be coming back from war. It could be being a victim of rape. All these sorts
Right,
of things can trigger
right.
depression. But I think brain injury is
Okay,
different. It's independent.
okay.
Can I offer a speculation that kind of rides on that, on your speculation, except it considers I've been calling them core problems, but for each person it may be different, but lack of cognition, the hearing problems, the vision problems, the problems that are literally what changed in us with the brain injury, if they don't get dealt with, that leads to the depression because you're stuck, or at least it contributed to it because you're stuck with those problems and they don't go away, and worse, they're invisible. So, everyone I meet is trying to struggle to find someone to help them with like they categorize who can help you with what, and then those problems stay in you. That was part of your list you had earlier, the executive function, the hearing problems, also headaches, but I think the headaches come from those other problems, and then you're stuck with it, and then the depression, maybe it snowballs or maybe it just accumulates, but I think it's and in that sense, what you explained is kind of consistent with how your body's shifting and getting worse because those things are still there.
Yeah, I think both those things are happening, and it's but a thing that we often see is even in people who don't have all the things that you just described. Some people could develop have a TBI and don't have all those complications. There's still an increased risk for depression afterwards, and I think all these things are independently contributing.
Okay.
Like you applied, or similar to the example I was giving earlier. Let's say if somebody is a victim of something horrible like rape or some other sort of trauma, that person also has a massive emotional burden. They also have invisible wounds, but their depression still looks different from the people who have a TBI. So I think
Hmm.
all these things are occurring independently of each other. I think Julia
Thanks.
has a hand raised, but is on mute.
Someone else, Julie, you have a question?
Same here. Yeah, I got a question. What about if the depression can become so deep that can you slip into a coma?
It is possible for really deep depression to cause something that we call catatonia. It's uh,
That's
and
different than a coma.
I'm sorry.
That's different than a coma.
Technically, it's a little different from a coma, yeah. Is it possible for severe depression to cause a true coma? I've never heard of a case of that happening. Of course, the brain is complicated, so I can't rule out the possibility that it would happen. But
Uh,
I've never heard of a case of a coma occurring in somebody who has depression, but no other neurological complications.
okay, thank you.
Okay. Uh,
Hmm.
Let's keep going with the talk.
Yeah, no worries.
Thank you all for
It can
questions.
also lead to TBI-associated depression also leads to often difficulty inhibiting emotions, which can lead to irritability and impulsivity. That's something that we don't see in patients with depression without TBI. And it's also sometimes associated with this phenomenon we call anosognosia, which is a failure to recognize one's own symptoms. Whereas in people with major depression without a TBI, it's more often to get, or it's more common to get a tendency uh, to be overly self-critical rather than failing to recognize your symptoms. These are all things that vary from person to person. One thing that seems to be consistent is that TBI-associated depression tends to be resistant to all conventional antidepressant treatments. None of the usual antidepressant medications work, and none of our usual psychotherapies work very well either. And so all these things are one of the reasons why many of us in the field had started to believe that TBI-associated depression is not the same thing as TBI plus depression. Uh, the emotional burden of the TBI certainly is burdensome, but there's something else going on here because it's different from just from other emotional burdens that cause depression. And of course, the conventional treatments don't do the trick, so we have to do something, but we have to find something better. So I showed a bunch of symptoms that we often see in people who are suffering from TBI, and we've been thinking about how do we approach these symptoms? What do we do about it? Well, I often, if you talk to me a lot, you'll hear me say this all the time, is that we don't need to reinvent the wheel. There's some things that we know that we can potentially apply. So there's a really great editorial by David Brody, who's a recognized expert in TBI, about how do we treat traumatic brain injury. And he said, well, you treat traumatic brain injury the same way that you eat an elephant. You do it one bite at a time. And that's how we do it right now. It's the best we can do. So uh, treat each symptom as you can because we don't have a good treatment for the underlying disease. So the goal is to minimize somebody's disability as much as we can because we, if we try to over medicalize it and say I want to cure the disease, we might end up going nowhere. So one symptom that we can treat in some cases is depression. A treatment that I'm going to talk a little bit about here is something called transcranial magnetic stimulation or TMS. And I'll explain to you in a second why I'm talking about this. There's a tool that uses electromagnetic induction to focally induce an action potential. In other words, it uses a magnet to fire the electricity in your brain. It's pretty focal. It's about a centimeter in radius, so it allows us to target specific brain circuits. And when we do it repetitively, when you repeatedly fire a brain cell or brain circuit, it actually induces long-lasting changes, which can last hours to even weeks, depending on the dose. It can be applied in a manner that's excitatory or inhibitory, so we can activate a brain circuit or inhibit it. And it's relatively safe. Very rarely it can cause a seizure, but that is so rare that it's something on the order of about 1 out of 30,000 treatments. So most people are willing to take that risk. Now, the reason why I'm talking about this is that this is a treatment that's often used for major depression. There's actually an FDA-approved treatment for treatment-resistant major depression. It's more effective than trying additional medications or psychotherapy. So people often use this treatment when they've tried 4 different antidepressants, then the next treatment is often TMS. The probability of responding to TMS for that person is about 50 to 70%. The probability of responding to a new medication for that same person is usually less than 10%. And I see a new hand raised from Maria. And Julie, I see your hand is still raised. Is that
Oh,
intentional or is it?
I forgot to put my hand down. Oh my God. I'm sorry.
Thank you.
Hmm.
Yeah, Maria.
I was just curious for folks that have metal plates in their skull, are we also candidates for this type of therapy?
It depends on the type of metal. If it's titanium, then yes. If it's something else, then probably no. If it's MRI compatible, then it's also TMS compatible.
Oh, it looks like a fancy lobotomy.
It does look like a fancy lobotomy. Of course the difference is that lobotomies cause permanent brain damage, whereas TMS does not. It tends to be a transient effect. And like I said, we know that it's pretty safe. It doesn't cause cognitive side effects and things like that.
Mm.
It's at this point, TMS has been given to I think over 2 million treatments have been given worldwide, and we haven't yet detected any cognitive side effects. Of course,
Hasn't this been used for treating Parkinson's as well?
it has been used for treating Parkinson's. It works for Parkinson's, but for Parkinson's,
Yeah.
unfortunately, it doesn't last. There's
Huh.
also something called DBS or deep brain stimulation, which is a surgical implant. That one works better for Parkinson's because it stays in there and it continues to stimulate. Now, in general, it requires about 20 to 30 sessions. They used to be about 30 to 40 minutes, but the newer protocols are actually faster. They're as little as 3 minutes. And most of the time, when people get better with this treatment, they're still better a year later. However, we're still a little bit crude about how we apply the treatment. It's based on scalp measurements rather than brain imaging. And that's how it's done in most places. The reason they do it that way is because it's feasible and because it works. So how to do this clinically? It's most commonly used for major depression. But other targets are also, oh, by the way, another thing that's different about this compared to lobotomy is lobotomy is breaking something, is reducing activity. TMS is increasing activity. And so and of course, the fundamental difference is the most important difference is that we've done it a lot and we know that it's safe. Other TMS targets are now also FDA cleared for OCD, nicotine use disorder, migraine, and anxious depression. And there are randomized controlled trials, that's what RCTs mean, sorry, It is supporting the use of TMS for various neurological disorders, including stroke, Parkinson's disease, and late life depression, often with comorbid Alzheimer's disease. However, it's like I said, it doesn't work as well for these disorders. That's why it's not FDA approved yet. In the case of stroke, it works for some people, not others, and we haven't figured out who. In the case of Parkinson's, it doesn't last, and that's why we don't usually use it. For Alzheimer's, we don't have a great way of measuring the long-term outcomes because it progresses so slowly that the studies still need to be done. However, this has led to a lot of interest in TMS for neurorehabilitation. The idea is that this modulates the excitability of the brain. So if you modulate the excitability of the brain, you might be able to focally enhance the brain's ability to adapt. It's a principle that we call neuroplasticity. That's why people have found that it's a promising tool to help in stroke rehab. If you have a damaged brain area, then you can try to excite it and try to help accelerate the healing process. Or you can inhibit the opposite side to prevent miscommunication between the left and the right. Or you can even excite the opposite side to accelerate relocation. So, for example, if I have damage to my speech centers, what usually happens is your speech centers try to relocate from the left side to the right side. And so you can try to stimulate the right side to help accelerate that. But all of this is preliminary. These are small studies. None of this has been conclusively proven. The only thing that we know conclusively is what I showed you earlier, that in terms of FDA clearances, that this definitely works for depression, definitely works for OCD.
Can I make a comment that I do also have that impulse of like, ooh, this looks too invasive, or well, I don't know what the word is, but I know that major depressive disorder, the people who are using it have tried many, many things, and it's kind of like if everything else worked, they wouldn't resort to this, is how I look at it. And my other question for you was, what in my experience with recovery and in discussions that with people that I've had, who the work and effort to restore the things you lost is what changed, and the plasticity takes a tremendous amount of effort on your part. It seems to me like it would be cheating to stimulate and get the same effect. I was wondering if there's any research showing that you need to stimulate plus have the person doing the effort, or if the stimulation alone is actually enough to restore.
Yeah, that's a good question because of course we would love to cheat to get people better faster if we could break the rules. But the question that you're getting at makes sense, which is that are you just doing it from the outside or are you helping people learn something from within?
Yeah,
And
like if they were concurrently doing the activity while that stimulation. I don't know. Yeah, I'm thinking of
Yeah,
it.
so essentially every time you focus on learning something, your brain stimulates itself. The question is, are you choosing to stimulate it from internal activation or from an external source? And so the comparison that I often make is if you break your wrist, there'll be multiple approaches to treating it. One is you're going to put in a cast from outside, but you're also going to do exercises to help restore its strength from inside. And if you don't cast it, you'll never be able to have the scaffolding, the strength to allow the healing that will then allow you to do the exercises. But if you don't do the exercise, then it'll always stay weak. So you really need both. And so so this is similar to that, is that often the brain system that's not working very well, telling that person that, oh, you just need to work harder. That comes off as implying that they don't care and they're not working very hard. And a lot of the people who I've treated who suffer from severe depression and with or without TBI, and I'll say that includes many of my own family members. If you tell them that well, all you have to do is work harder on learning the skills to recover, uh, they find that incredibly frustrating because it implies that they're not already working hard enough, which they are. They're trying the best they can. It's just when you're trying the best you can and it's not working, then we try to facilitate additional ways to try to help. And just like if somebody had a broken wrist, you wouldn't tell them to just exercise it more. You would repair it first and then exercise it. So that I think
In,
that's the analogy I often use.
Dan, what he just said is making me think about that. I think he just drew an analogy between what I'll call the external methodologies, treatments, what have you, as opposed to the internal being the meditation, anything along the contemplative sciences. Would you agree with that, Dr. Siddiqui?
Yeah, 100%. I think uh, there's there's no question in my mind that meditation is an effective treatment for depression, for anxiety, and for a wide variety of other things. Uh, it's uh, uh, it's easier for some people than it is for others. When I talk to some of my patients
That's an
who are,
understatement.
yeah, right.
Yeah, that's an
Uh,
understatement.
when I try to teach meditative skills to some of my patients who are suffering from really severe illnesses, they'll say that I just can't do it. This is too much for me.
Yeah.
And they need help from outside. And so what I find is some people can do one or the other. Well, at least what I usually do for people in the real world, for patients, is to say, here are the options that we have available. Which ones best suit your life? And then they usually make the decision for themselves. Some people will say, I want a pill. Some people will say, I want psychotherapy. Some people will say, I want to avoid all those things and go to stimulation. The most common reason actually why people turn this type of treatment down, is because they don't want to deal with parking in Boston, which is fine. If that's your reason. Parking in Boston is really frustrating. But it's uh, there are a lot of different reasons why people choose different things. But I find that the best thing is to have the options so that people can then choose from them. And then Julia, you have your hand raised again?
Yeah, I'm sorry. I've got a question. I've been told for the last 15 years that depression is a chronic disease, as is bipolar and that sort of thing. So how do you get rid of the chronic aspect of things if it's chronic?
Yeah, so there are a lot of chronic diseases out there that we don't have cures for. I think depression is one of them. And I don't think I have a solution to that problem right now.
All
We don't
right.
have a way to make it any less chronic. What we do have is what we're trying to do is finding ways to make it less disabling.
Oh, all right. Thank you.
Okay. And it's there are some people there are people who are working on that also, is to try to find cures that'll completely get rid of the disease altogether. But again, drawing an analogy to other areas of medicine, it's when we have a patient who has asthma, for example, our goal is to have them live a completely normal life, just taking some treatments to keep it as normal as possible. We have a similar goal when we're treating depression and especially bipolar disorder. It's And I'll tell you again, I have a lot of people in my family who suffer from major depression and from bipolar disorder. And so I have a very personal interest in this, in addition to treating patients who have these diseases. And I've found that uh, it would be great if we can get a cure, but I think that's sort of still a long way away. For now, the most important thing for many people is to be able to live a normal life.
Yeah, I'm more comfortable. Yeah.
Um, and then a final point here is that there are a few studies that demonstrate that TMS does seem to work for TBI symptoms, including headaches, cognition, and depression. And it's being used in various clinics for TBI-associated depression. But one of the challenges is if we're stimulating the brain, we want to make sure we're picking the right spot in the brain to stimulate. We don't want to be doing a lobotomy, like you said. So how do we find that right spot? I'm going to jump into the science a little bit here, but I won't go into too much detail. I'm going to keep it a little bit superficial, just to give you an idea of how we find this stuff. But you're welcome to ask questions if you'd like to later. Traditionally, the way we've found what different brain regions do is by looking at brain damage, incidental brain damage. So if somebody had a stroke and three different people had three different strokes and they all sort of overlapped with the same spot, we say, oh, well, that's where all those different strokes overlap. That must be where that symptom comes from. However, in reality, this gives us information about what systems in the brain are causally involved in certain symptoms. In reality, however, often it's not that simple. You have different people who have different types of brain injury. Some of them overlap, some of them don't. And people started looking at this and saying what I was hearing earlier, that maybe it's just the disability from the injury that's causing the depression, and it's not the physical damage to the brain itself. And It's clear that the disability from the injury is a driver for depression. But we've also found that if it's not just about the location of the injury, it's also about its connectivity. So there's this new tool called the Human Connectome Project, which is like the wiring diagram of the human brain. Using that wiring diagram, we can figure out that certain types of brain damage, even when they don't overlap with each other, they can be connected to the same network, or they have similar patterns of connectivity. What do we do with that information? Well, if damaging this system causes depression, then stimulating the same system should relieve depression in theory. And so using this wiring diagram, we can find targets to stimulate to relieve the symptoms. So I'll say that again. That's the basic premise of what I'm going to talk about for the next 10 minutes or so, which is that if damaging something in the brain incidentally causes a symptom, then stimulating the same system should, in theory, relieve the same symptom. And I'll show you how we've tested that hypothesis. Um, for example, uh, we can find a bunch of incidental patterns of brain damage in people with TBI and localize where it's present. So, for example, in this particular patient, they had an area that was damaged over here, and we had a lot of information about what happened afterwards. We can also look at these stimulation sites, either with transcranial stimulation, which is the superficial one that doesn't require any implants or anything that I was talking about earlier. We can localize them on a brain MRI and say, where did we incidentally stimulate? We can also look at deep brain stimulation. So Rand was asking earlier about Parkinson's disease, for example. People with Parkinson's disease also often get a brain implant to treat their Parkinson's, but incidentally, some of their depression gets better or maybe even gets worse. And so we can localize where they were incidentally stimulated and use that, compare that to figure out what happened to their depression. And here's what we get. It all converges on something in common. If it does, then that tells us something important. Here's what it looks like. This, again, is a bunch of fuzzy brains, but essentially, on the left here is the connectivity of brain damage sites that cause depression. If your brain damage is connected to the yellow stuff and negatively connected to the blue stuff, you're more likely to get depression. The same thing seems to be true for stimulation, except the opposite. If you stimulate the damaged regions that cause depression, it seems to relieve depression, and vice versa. This is true whether we use TMS, the stimulate from outside the brain, or the implants that I was talking about earlier. So what does this mean? I showed you a bunch of science, but this means that these three different things, TMS, which is a non-invasive stimulation, DBS, which is an invasive stimulation, and brain lesions, can all modulate a common brain circuit. So in other words, people who've had incidental brain damage can teach us something about how to find new treatment targets, even for the people who don't have physical brain damage. So one place where we've taken this is PTSD. We looked at the Vietnam head injury study, which is 193 Vietnam veterans who had penetrating TBI, and compared them to a bunch of veterans who had non-neurological injuries of similar severity. And this actually gets to the question that Rand was asking me earlier. Doesn't the emotional trauma from the injury cause a big issue? Well, it turns out in this particular group, the people with TBI were actually less likely to develop PTSD than the people with non-neurological injuries. And this was significantly different statistically.
Say that again. Say that again.
Yeah, I'll say it again. So people with TBI were actually less likely to develop PTSD than people with orthopedic injuries in the Vietnam War. Now, that's strange, right? That's surprising.
Yeah, it's very surprising.
But it turns out, so I'm going to tell you what we learned from this. It turns out it was actually lesions to the amygdala that were protecting against PTSD. So in people who had damage to the fear regions of their brain, they were actually less likely to get PTSD than people who had emotional trauma without brain trauma. And so that tells us something.
I don't get that. How do lesions to the amygdala, which is at the center of your limbic system, protect you from PTSD?
Yeah, so I'll clarify. First of all, we don't know why. We just know what happened. But what I think the reason is that the amygdala is the region of the brain that creates fear. So if you damage the region of the brain that creates fear, then we think you're probably less likely to get fear. And Dan, I think you were trying to raise your hand.
Oh no, I was just going to speculate basically that exact same idea that
You know,
what is underlying that fear response, which is a critical part of the initial experience of what later leads to the PTSD. Also, I had a question, but yeah, I just wanted to, yeah.
last night on 60 Minutes, they were interviewing a doctor. I don't remember his name or where he was from, and he was dealing with Parkinson's and some other issues. What he was describing in terms of their the methodologies that they were using had to do with using sonograms. as opposed to, in this case, what you're describing as magnetism. But it sounds very similar in terms of, how they ended up approaching it. If you go to, I guess, 60 Minutes website from last night, you might be able to
Are you
find out who
talking
the
about
guy is.
the focused ultrasound treatments? Is that what they were talking about?
Yeah, that was it. The focused ultrasound.
Yeah. So for
You know
focused
who I'm
ultrasound,
talking about?
do I know what you're talking about? You're saying?
Yeah, you know who,
Yeah. Yeah,
yeah,
I'm familiar with it.
yeah. That's what
Yeah.
this sounds like. Only you're using magnetism.
Yeah, in principle, it's similar. The difference is that with focused ultrasound, they actually physically they actually induce an irreversible change. They induce a permanent change. TMS does not introduce a permanent change, but otherwise, in principle, they're very similar.
Hmm,
Uh, and
interesting.
Maria has a hand raised.
Maria.
I was just going to ask, when it comes to the lesions to the amygdala, is it possible for that to heal? And then if that patient were to have another traumatic incident, they would be impacted and perhaps diagnosed with PTSD?
It's possible, but we don't really know for sure because in this case, of course, the people had the traumatic episode at the same time they had the brain injury, right? They had a missile fired at their head. And so they had a massive emotional trauma and a massive physical trauma at the exact same time. So it's strange that those people were less likely to get PTSD. And so it tells us a lot about that region in the brain. If we look at just the amygdala, on the other hand, there were other people who just had the emotional trauma without the physical trauma, right? Because the control group here also had emotional trauma. They also had physical trauma, just not to their brain. So it turns out the emotional trauma was associated with PTSD, but the brain trauma could do it in different ways. But what would happen if they had another traumatic episode in the future? I don't necessarily know because I can't. We didn't test that. If I had to speculate, I would guess that because they've got damage to the amygdala, they're probably protected against PTSD in the future too. Because we know that the PTSD lives in the amygdala. It's a fear response. And so if you can't get fear, then you might be protected against PTSD. Now, that doesn't mean that we should damage people's amygdala. It serves an important role. But this tells us a little bit about how PTSD works. Uh, and so the purpose of this is not to say we should break people's brains, but to say that we should learn from what incidentally happened to these people, unfortunately, to try to help other people in the future. So in this case, for example, the amygdala is too deep in the brain to get to with TMS. TMS is a superficial technique. However, uh, you could reach the amygdala with focused ultrasound, the other treatment that you were talking about, but we don't have enough safety data to say that it's really safe to permanently change the amygdala. So we're not ready to start doing that yet.
Hmm.
The question is, can we map a circuit to show that is there a spot that's connected to it that we could target in a reversible way with TMS, so that might be a little bit safer. So we looked at the
But
connectivity of lesions that reduced the PTSD risk versus the ones that didn't. And here's what we found. On top is the locations of these incidental lesions. Again, these are people who had these patterns of brain damage a long time ago in the Vietnam War. We mapped their connectivity using this connectome database I was telling you about a minute ago. And we looked to see whether they developed PTSD or not. And it turns out people who were protected from PTSD, their patterns of brain damage were connected to the medial prefrontal cortex, amygdala, and hippocampus. These are brain regions that, like Rand was pointing out, are involved in the limbic system. But interestingly, it wasn't just about the amygdala. That we get the exact same effect if we drop all the lesions that touch the amygdala. In other words, it's not just damage to the fear areas of the brain that protects against PTSD. It's also damage to the regions that are connected to the fear regions of the brain. So that suggests to us that stimulating the fear regions of the brain might help us find better treatment targets. We also tested this in an independent group of veterans who had TBI, or some of whom had TBI, some had PTSD, but none of them had structural brain damage. And they were on fMRI, there was less connectivity in this circuit in people who had PTSD. So this seems to be involved in PTSD with or without a brain injury. Again, the brain injury data were just there to tell us a little bit more about how learn a little more about PTSD. But there's not to say that we should damage people's brains, of course, but by using those incidental patterns of brain damage, we might be able to find better ways to treat and modulate PTSD. So what we're suggesting is that this is our new TMS target, and that if we could suppress activity in this brain circuit, we might be able to treat people who have developed PTSD with or without a TBI.
So
That's what
what's the name of this circuit, or what is this circuit?
we don't we I haven't given it a name. It's not even published yet, but it's so we're just calling it the PTSD circuit. Or the one I showed you earlier, we're just calling it the depression circuit. Other people start the depression one we published, people have been calling it the causal depression network. So I suppose that people will probably start calling this one the causal PTSD network once it gets published. But like I said, it's not published yet. Um,
And I mean, we already have had brain injuries or brain damage that you had mentioned not to do it to people, but since it's already happening, we might as well use what is there. Absolutely. And I just wanted to share that in my effort to understand what had happened to my mind after my brain injury, I was learning, as much as I could about the brain, and I got into neuroscience, and I see it as circuits upon circuits upon circuits, and we're discovering them new
yeah.
every day. And the nature of the circuit is kind of how many things work. So this is exciting and interesting and consistent with what the way people think about the brain now. It's really
Yeah,
cool.
exactly. The whole circuits upon circuits thing, I agree with completely. We were still working on figuring out how to best understand that hierarchy. But it does seem that, and that's something that we're probably not going to figure out tomorrow. And so the approach that I've been taking and what I'm talking to you guys about is, while we wait to figure out all the questions, how can we find treatments that work? Because we're not going to figure out the answers to all the questions anytime soon, but we have people who need treatments today. And so we're looking for shortcuts to find treatment targets while we wait to understand the entire cause of the disease. And so this is
You're part of Mass General, correct?
I specifically work for Brigham and Women's Hospital, which is
That's
a
part of
sister
Mass
hospital.
General. That's where John Kabat-Zinn is,
I don't know that
right?
person, but there are
John,
600 people in the psychiatry faculty at Mass General, so I don't know all of them.
Randy, let's save those
okay.
questions for
Who
later.
is that?
I'm wondering about, have you done anything, any of the research? I'm trying to think of how to pose the question. Um, that has been way outside the box, unconventional.
I mean, the way I tend to think
That's a
about this
pretty
is like,
broad question, I realize.
yeah,
You
yeah. I mean,
know.
my approach to research is to say, here's the box. What is the edge of the box? I want to be just right at the edge, but not too far outside because
Okay,
we care a lot about not inadvertently hurting people. Uh,
right.
but
Have you
I don't know
done
if that answers the question you're trying to ask.
any research around the use of organic psychedelics,
No, I was feeling a question.
Yeah, I don't
psilocybin?
study psychedelics myself, but I know a little bit about the people who have been studying them. For example, there was a really great study on ibogaine that just came out
Yeah,
last.
I just read something about that. The problem is some people have died from using ibogaine, but whatever.
Yeah, yeah. And so in that particular study, they did very, very careful cardiac monitoring for that reason.
Right, right.
And I wrote an editorial on this, which is coming out next week, or maybe the week after. But the point is that I think it's promising, but you're pointing out an appropriate concern, which is that it hasn't been studied very thoroughly yet. And so I'm not sure if we fully understand the risks and benefits of psychedelics. I think that there'll be a huge role for psychedelics in neuropsychiatry in the future once we figure that out.
I
But
have a question.
that's not my area of expertise.
That's okay. That's okay.
Yeah, let's get back to the talk, but also Julie has a question. And Julie, yes.
Yeah, yeah. What is it called when the brain convulses into like a seizure type thing where it swells? Is that what a seizure is?
There are a lot of different
Encephalitis?
things that can cause a seizure. Brain swelling can be one cause of a seizure. Yeah, that's called cerebral edema, to answer your question.
So you wouldn't use your theories to help that. You would use like a
We,
something to
we
help the seizures go away, period.
We haven't, so I haven't studied that directly. There are some people have looked at a similar approach to study seizures. And there are a lot of different kinds of treatments available for seizures. But again, seizures are not my expertise. I'm a psychiatrist. And so I think that might be a better question for a neurologist.
Oh, I see. Okay, thanks.
No problem.
Dr. Siddiqui, can you speak about the individualized versus group average data of this study? And
Yeah, so let me skip ahead to that actually, since you guys have asked a lot of great questions, but that's since we're running a little short on time now. Not all brain injuries are the same, right? And I'm sorry, the slide's coming through a little fuzzy, I think. Uh, Brain organization is quite heterogeneous between people, but consistent within people. Just like your nose looks different from my nose, your brain looks different from my brain. And the question is, how can we map that and understand it? Our inability to map that heterogeneity was one of the reasons why we were having trouble understanding TBI depression for a long time. So, for example, these are three different people's brains, and not knowing anything about what the colors mean, each of these colors represents a different network or a different system in the brain. Each of these systems has a different function. For example, the red stuff is the default network that's involved in internally oriented reflection, rumination, things like
Mm.
that. When that goes haywire, it can cause potentially over rumination. And the blue stuff here is the dorsal attention network, which is involved in externally oriented attention switching. So that interaction between externally oriented attention and internally oriented attention is one of the things that we think is not working very well in people with TBI. You get stuck inside your own head and can't get out sometimes. Uh, and so, so we wanted to study this more. For example, on the left is the organization of these networks in a patient with a repetitive TBI. This guy was a retired NFL player. And the person in the very in the middle and the one on the right were people who were just healthy controls. And they're not, again, not knowing anything about what the colors mean, you can see they look different. Not everybody's the same. And so for a long time, people were starting to study abnormal connectivity in TBI, but they weren't looking at this individualization. They still found useful things in these networks that I was talking about, the default mode network and the dorsal attention network. On average, TBI was altering this connectivity, but they found that it wasn't really associated with depressive symptoms or PTSD scores. The reason why I bolded those words, symptoms and scores here, is because I think I was reading this study as a psychiatrist and saying, well, depression is not just a score. PTSD is not just a score. It's a source of disability. Either you have it or you don't. Right? People who have PTSD, people don't have just a kind of maybe PTSD. If you have PTSD, you have PTSD. And the scores are, I think, misleading. So we looked at this again, but we did two things differently from the studies that had been done before. One is that we treated depression as a binary thing. My hypothesis that I've been telling you about this whole time is that TBI depression was is a distinct phenomenon. It's not just a reaction to the disability. The reaction to the disability is definitely part of it, but there's also a distinct brain phenomenon. That was one. The second was that we need to personalize these brain maps. And here's what I mean by that. The technology is a little bit fancy, and I'm happy to answer questions if people want to know about how this works. But on top is a group mean map of those brain systems that I was just talking about, that externally oriented dorsal attention system and the internally oriented default mode system. The yellow is a subgenual cingulate, which has long been believed to be a region that's involved in depression. If we individualize the locations of these networks, you can see they mostly look the same, but they're different. The individualized networks are not exactly the same as their group mean locations. So when we look at connectivity between these brain regions, we need to personalize them because every brain is different. We didn't have the technology to do this until very recently, and I think that's why nobody detected this effect until very recently. Uh, I want to draw your attention to this spot here, the dorsolateral prefrontal cortex. This is the usual spot that we target with TMS to help people with depression. But it's you can see at the individual level, there's a spot there in the dorsal attention network, but everybody has it in a different location, so at the group level, it washes out. So this is just an example of why individualization is important. And we use this to distinguish depression after TBI. Here's what we saw, interestingly, about connectivity in this network. On the left here is connectivity within this circuit in people who are not depressed. Regardless of whether they had TBI or not, the connectivity was about the same. So the circuit was basically the same this particular circuit was basically the same regardless of whether you had TBI if you weren't depressed. But if you were depressed, it went in opposite directions. In other words, depression after TBI was physiologically different from TBI without depression. They affected the same network, but in different ways. Um, and then we found the same thing in an independent data set, that people without depression had the same connectivity in this circuit, regardless of whether they had TBI or not. But if they do have depression, it went in opposite directions. This suggests that there's a physiologic distinction between TBI without depression, uh, depression without TBI, and TBI associated depression. So and it's centered around this dorsal attention network. We gave it a term too. We call it a TBI affective syndrome. Affective means sort of emotional. So an emotional syndrome that happens in TBI. It seems to be physiologically distinct. It also predicts therapeutic response. And a few people who had, in an independent clinical trial of TMS in people who had TBI-associated cognitive symptoms, everybody got stimulated at the same spot. But the more connected their stimulation site was to the circuit that I just showed you, the more likely they were to have improvement in depression. This HAM-D means Hamilton Depression Rating Scale. This was true with real stimulation, but not with placebo. We showed it in our own trial also. We did a pilot clinical trial in people with TBI-associated depression, where we mapped this precise target in a few people with TBI. And it turns out when we gave them stimulation, they did better with active stimulation, but not so much with sham or placebo. So the treatment seemed to work, and it seemed to be safe, but it was in a small sample. It was only in 14 people. We're now trying to replicate this in a larger group. So
Widely available is this
Yeah, man.
the I'm sorry, what did
TMS.
you just call it? TMS.
TMS.
Yeah.
It's a bit there are a few TMS clinics in every city. Uh, it, it's of course, like any medical treatment, it's more widely available in a place like Boston than it is in most other places. But
Does the
so, for example, can
insurance
I ask where you're
industry treat
located?
this as experimental?
It's not experimental. It's been FDA approved since 2008,
Okay, okay,
uh, and it's usually covered by insurance.
okay.
But can I ask where you're located?
I'm in Eugene, Oregon.
So there's I'm sure there's probably in a
Probably
place
up
with
in Portland.
university. Sorry?
It's probably up in Portland.
No, I'm
OHS.
sure there's a place in
OHS.
Eugene.
Yeah.
I actually know that area a little bit. I know there's definitely a place in Corvallis. It's there are many places in Portland, but I'm sure there are places in Eugene because
Okay.
given how big the University of Oregon is, uh, it's
Should be
there's
that difficult to track down.
yeah. I think if you
Okay.
just Google it, it'll be easy to find.
The circuit that you're talking about in the last few figures, it's not the same as um the one that you were speaking about earlier with
It
PTSD.
actually is. It's very
It,
similar. It's just it's affected differently depending on whether you have TBI depression or depression without TBI.
okay, that was my question. It seems similar, at least on the figure. So yeah,
Yeah. It's the reason why it looks a little bit different is because they were derived slightly differently. And the circuit that I showed earlier, the for complicated reasons, we don't quite have the technology to personalize it, so we used a similar circuit that can be personalized, but they're almost identical.
okay, cool.
Um, let's say you have multiple TBIs and you've had the TMS.
Mhm.
Can the TMS be uh, disrupted and need to have to keep doing it again after there's multiple other TBIs?
It's possible, and TMS, like I said, is not curative. It makes people feel better when it works, but it doesn't prevent you from getting another episode in the future because depression, as you mentioned, is a chronic illness. So uh, we can get people out of depression. Sometimes it lasts a year, sometimes it lasts 10 years, sometimes it lasts 6 months. We don't necessarily know when the next episode is going to come. So you might not even need another TBI to trigger a future depressive episode. We don't really know the answer to that.
What I was saying is, if someone has had multiple TBIs, would in between the TBIs you had the TMS, would you have to have the TMS again to help the second or third TBI along?
It's possible, but as far as I know, nobody has figured out the answer to that question for sure.
Okay. Hey, thanks.
Mhm. So let me summarize what I just told you. First of all, focusing on what's next. So what can we do now, and what can we not do now, and what do we hopefully be able to do in the future? So TMS is not approved specifically for TBI affective syndrome. There's a disorder that I've been telling you about that we're trying to define, but it's available for depression in general. And we think that TMS for depression in general can work for the TBI affective syndrome. Pragmatically, depending on insurance, it's usually only covered for people who've tried at least 2 to 4 antidepressants. It's available in most cities. It works for about 50 to 70% of people with depression. And like I said, appears to work just as well for TBI affective syndrome, even though the other treatments don't work. That's what I think we can do right now. What can we not do yet? We don't yet have a brain scan that can diagnose this TBI affective syndrome. So the study that I showed you about just now was something that told us about the disease in general across a large group of people. The technology is not yet good enough to make the diagnosis reliably in individuals. And I mention this because I've had a lot of emails from people, journalists, and a lot of other people have been asking me, can I use this to make a diagnosis? We're not there yet, unfortunately. We're working on it, but we're not there yet. We also don't know exactly why this happened. So this is talking again about the question that Ran asked me earlier, is that why does it happen the way it does? Why does TBI affective syndrome hit these systems differently from other types of depression? Why do there certain brain systems? We think that it has something to do with where in the brain these systems are organized. With a brain injury, even if you don't have any focal specific locations of brain damage, your entire brain undergoes, unfortunately, a bit of a shear stress. It twists on itself a little bit. And so the longest pathways in the brain seem to be the one that are affected. Those longest pathways are the limbic system, the emotional systems in the brain. So those seem to be the ones that are most affected, and that perhaps the brain doesn't prioritize healing those as much as it prioritizes healing other systems. We also don't have a fully tailored treatment for this TBI affective syndrome. We can adapt TMS for depression, but I think there are better approaches down the line. And finally, we can't yet track the brain scans to see if somebody's doing better or worse. That's another thing that we're working on to improve the technology. Yeah, Maz, is that right? Did I say that right?
Yeah, hi. I joined it late, your conversation. So I apologize if you addressed this, but it's a broad question. How did you differentiate in studying TBI depression with fatigue?
We in some components of the data, we've looked at depression versus fatigue in some of these studies, but not all of them. And it seems to be independent of fatigue. So we can statistically control for that to say if we essentially hold fatigue, if we look at only the people who had no fatigue and only look at the effect of depression, and vice versa, people who only had depression but or had no depression but only had fatigue, and then you can develop progressively more complicated statistical models to include all that information together. And the short answer is that it appears to be independent, that the system is about depression, and many people get depression causing fatigue. There are also many people that get fatigue without developing depression. We haven't studied that yet.
That's fantastic. Just in general, my experience personally, they do a kind of a personality test, question test to diagnose depression, and a lot of the questions um, that I answered that steered them toward depression was actually fatigue, sleeping a lot and things like that. So it would be great to really focus in on these distinct areas. And I
Yeah,
really appreciate your work. Thank you.
no problem. Thank
There's
you.
a huge fatigue that comes with brain injury, and
Yeah,
yeah,
depression can cause fatigue. Fatigue can cause depression. Brain injury can cause depression. Brain injury can cause fatigue. So all these things are interrelated in a very complex way, and it's something that it's I think it's important to learn more about, but I don't have an answer to that question yet.
But when you have psychologists question and answers and their results lead toward depression when it's not depression, but it's actually fatigue,
This is
that's a
why I was
problem.
saying earlier that I don't like it when depression is distilled down into a score, into a number.
Yeah. Yeah. Okay.
That's not the
Thank
way
you.
to diagnose depression. It
Yeah.
should be based on a full longitudinal conversation. I actually teach my students this fundamentally, who that You don't diagnose any psychiatric illnesses based on just how somebody's feeling at the moment. You have to track how they felt over time, what have been the ups and downs over the years. Those are all important factors.
Thank you.
Oh, what about the encephalogram, the angioencephalogram?
Yeah, so the EEG, the electroencephalogram, is usually used to diagnose seizures. It hasn't been used, or it hasn't been proven to effectively diagnose anything else yet.
Yeah, that's what I was wondering about that first statement that you made because you don't have a know about. So okay.
Can I read a question that someone messaged me about mapping the circuits? Would that be influenced by childhood injuries? I guess childhood brain injuries specifically, and obviously development.
Yeah, it's certainly possible. We again, one of the many questions that we don't have an answer to yet, but I would expect that childhood injuries would affect it differently from adult injuries. We know that childhood injuries uh, increase the risk of CTE, for example, chronic traumatic encephalopathy, more so than adult injuries do. And so so we know that childhood injuries are different from adult injuries. But in the people who were included in the studies that I showed you were people who had adult injuries. So I think it's an entirely uh, independent group of people that we need to study in more detail.
Yeah. Thank you.
No problem. I'll mention a couple other things, then we're over time and I'm late for my next thing, so I unfortunately have to go soon. But we will a few broadly, the next few things we want to do is try to bring this into the real world. That involves following a path, proving that it works, partnering with investors or device companies, getting regulatory approval, and getting insurance coverage. And that requires collecting more data, which is something that we're good at, is running clinical studies. But we also need help in doing this sort of stuff better. We're good at brain mapping, but we need help with the rest of it, like partnering with funding agencies or investors, conducting large-scale clinical trials, which involves a lot of logistics, working with regulators. That's not my expertise. I'm a clinician scientist. These things are done in a huge team. So I just wanted to mention if any of you guys know how to do this kind of stuff, if you're good with logistics or with investments or with running a company or with any of these types of things, happy to talk more about that. Like I said, I'm unfortunate. We're running short on time, so I'm going fast here. But a lot of people help make this happen. Yeah, advocacy is a huge component of this. I see that somebody mentioned that in the chat, and that's I think that deserves an entire presentation on its own, not just a line on a slide. But I'll stop there and ask if there are any quick questions. But unfortunately, I only have well, like I said, I'm late for the next thing, so I can also take questions via email.
One question that I wanted to point out, I feel the individualized versus group average ability to look at that, I think it could apply to so many more problems with brain injury that look like other problems, like the fatigue, like the loss of self, like the changes that we go through that when you describe it to someone, they say, oh, it's like this. And it's not at all like that,
Yeah.
but it's just hard to prove it. So I think that
It's just the tip of the iceberg. I think this is just
exactly, yeah.
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 I think this opens up a whole new field of how we look at things, in individualizing and tailoring and personalizing. One of the reasons why we looked at depression was because of availability of data. A lot of people just had scans and had depression scales sitting around,
Right.
and so we were able to look back at them. But what I would really like to do in the future is get more detailed phenotyping, ask about things like fatigue, and do more detailed assessments of them. Look at reward, frustration, impulsivity,
Irritability, yeah.
yeah, irritability, executive dysfunction. These are all things that I think are independently important and are all independently affected by TBI. Like I said, depression, which is a starting point here.
Thank you, Dr. Siddiqui. I really
This
appreciate
was
it.
good.
Thank
This
you.
was good. Thank you.
No worries. Thank you.
All right. I think, can you change me back to the host? Just
Yeah.
click on my window.
Yep,
And
I'll make you a host there. And like I said, unfortunately, I have to go. But if any other questions, yeah, I showed you my Twitter handle and my email address. I'm not always good at getting to emails because often I think when I check my email, I'll probably have received 17 emails in the time that we were talking. So I'm not always good at getting to them, but you're always welcome to find me there or Twitter or anywhere else.
thank you very much. Yeah, I
Thank you.
understand you're busy. So I'm gonna stick around a few minutes. I